Okay, I think we'll go ahead and get started and as people are still registering in. Good morning, everyone, and welcome to our free webinar, Overview on Lung Cancer Therapies 2020, presented to us by our guest and key educator, Dr. Laura Chow. My name is Cecilia Zapata Harms, and I'm the president and board chair of Elevate Cure Foundation. And just a quick intro on the Elevate Cure. We're a foundation that started about a year and a half ago. And our primary focus is to support cancer research, patient education, patient charity programs. And we do several different events throughout the year. This is our a quick website and information. So if you'd like to learn more, please visit us on our webpage. A few housekeeping things. Everyone, all the attendees are muted right now. And at the bottom, I think most of you are fairly familiar on how to use Zoom, but there is a link there, a box for Q&A. So please feel free to type in your questions. We will answer them as much as we can with the time allowed to us. But we'll also, if there's an opportunity for you to also raise your hands, I believe, and we can unmute you and ask your questions live as well. But Q&A box is probably the better scenario. Both Dr. Chow and myself can see the questions that are posted there. The presentation is also being recorded, and that will be available probably within 24 hours on our website, as well as posting on our social media. So it is my great pleasure to introduce our key educator, Dr. Laura Chow. I've had the pleasure of working with Dr. Chow at the Seattle Cancer Care Alliance, as well as have many different opportunities to travel with her nationally and internationally for business. Dr. Chow is a professor of oncology with tenure and the associate chair of education in the Department of Oncology at Dell Medical School, University of Texas, Austin. She's also director of thoracic, head and neck malignancies and clinical immunotherapy programs, and the associate director of clinical research at Livestrong Cancer Institutes. Previously, Dr. Chow spent more than 9 years as the associate director of the phase 1 developmental therapeutics program and attending medical oncologist in lung, head and neck malignancies at Seattle Cancer Care Alliance, associate member of clinical research at the Fred Hutchinson Cancer Research Center, and a professor in the Department of Medicine, Division of Oncology at the University of Washington. She also, she came to medicine with a background in pharmacology and therapeutics and was inspired to pursue a career in oncology because of her personal experiences with cancer in her family, as well as her interest in clinical research. With that, we welcome Dr. Chow.
Great,
and
thank you so much.
Laura, you can just go ahead and share your slides when you're ready.
Sounds good. Just hang on one sec. Can everybody see the slides?
It looks like it, yeah.
Okay, great. So I'm really pleased to be talking to you today, and thank you so much for the introduction. It's an honor to be able to speak to you. At this time, this is virtual due to the pandemic, so I would have loved to actually have more of an interactive session. So please feel free, though, during this talk to ask me any questions during the Q&A, and we'll have about 15 minutes afterwards. So I would ask that you leave your questions to the end. And this is a particular topic that's of great interest to me. We're moving through looking at lung cancer from hopeless to hopeful. When my multiple family members as a young child, as well as in school, came down with lung cancer, there were not a lot of options available. And I've spent the last few years mainly looking at new treatments, and hopefully you'll be able to see some of the changes that have occurred, particularly in the last decade, as well as the last 2 years, have been very impactful for this disease. We'll learn the basics regarding non-small cell lung cancer and how treatment has evolved over time. We'll gain some knowledge regarding personalized targeted approaches in advanced metastatic disease, as well as update on first-line immunotherapy, and identify areas of further study in clinical research in advanced non-small cell lung cancer. Not surprisingly, cancer is still a leading cause of death in the United States, of which lung cancer is one of the most common causes of death. You can see that cancer is about to take over that of heart disease. And unfortunately, in the last year, COVID-19 is somewhere third at this time for leading causes of death. Lung cancer is very common. It's one of the most common cancers, the second most common cancer in males as well as in females, and has taken over all cancers in terms of being the leading cause of death in both males and females. There are two types of lung cancer: non-small cell lung cancer and small cell cancer. Today, I'd like to focus on non-small cell lung cancer, which is quite distinct in terms of it being the most common, 85% of all lung cancers. And this is a slower growing type of malignancy that grows in terms of weeks to months, but it's not as sensitive to chemotherapy and radiation as small cell. There are characteristic appearances for these cancers under a microscope. The first of all is adenocarcinoma, which is a gland-forming type of lung cancer. This is usually seen in the periphery, and it's associated with smoking, as well as commonly seen in non-smokers. Whereas squamous cell cancer is seen under the microscope like this, and it's a very aggressive type of cancer, almost always associated with smoking and a heavy smoking history. It tends to be very central, it tends to cavitate, cause problems with hypercalcemia, and cause major issues with bleeding. Thankfully, with the decrease in smoking, we're seeing less and less of squamous cell lung cancer. Sadly enough, cigarette smoking is attributable to 85 to 90% of our lung cancer deaths. The relative risk is 10 to 30 times that of a never smoker. We usually describe cigarette smoking in terms of pack years, as the risk is proportional to the number of cigarettes smoked per day and the duration in terms of years. Even though we highly encourage people to quit, and it's better to quit as soon as possible, the risk of lung cancer decreases when people stop smoking, and it approaches but never reaches that of the risk of death that a non-smoker would have from lung cancer. Why is lung cancer so bad? Well, lung cancer is deadly. There are not a lot of nerves in the lungs, so we cannot diagnose lung cancer until it has eroded through a major structure, such as your bronchus or breathing tube, or eroded through a blood vessel, or spread outside the lungs into liver, bone, brain, or adrenal glands, or even around the lungs and heart, causing pleural effusions and pericardial effusions. So unfortunately, this presents very late. As a result, the survival for these stages obviously get worse the later the stages. When we look at those that present early in stages that we can surgically resect, unfortunately, this is less than half of the cases. The majority present in stage 4, where cancer is already spread. You can see that in stage 4, these are statistics from over 10 years ago. The chance of surviving 5 years is 2 to 3%. So quite dismal, whereas in earlier stages, without lymph node spread, the chance of survival is quite high. So if we can detect cancer earlier, we can improve outcomes. At this time, blood-based tests are not available to diagnose lung cancer. And there are people at the University of Austin, Texas, and others working on a device to see if you can breathe and capture your air and see if you can diagnose lung cancer that way in the air that's exhaled. However, this is all very experimental and it's not ready for prime time. And hopefully in the future, we have better ways of detecting early lung cancer. In 2011, in the New England Journal of Medicine, it was quite remarkable that in 53,000 patients that were deemed high risk, and we'll define high risk in the next slide, between 2002 and 2004, there were 33 patients that underwent screening with either a low-dose CT scan or a chest X-ray. And it was very evident that low-dose CT scans could detect lung cancer early and decrease lung cancer death by 20%, as well as decrease overall chance of death by 6.7%. Despite the risk of anxiety, radiation exposure, which was very minimal, this actually saved lives and prevented death. So as a result, the US task force and several professional organizations recommended that for high-risk individuals, these are individuals that were included in multiple studies for screening, the population would be that of age 55 to 80. This has been somewhat expanded over the years. A minimal smoking history of 30 pack years, i.e. 30 years of 1 pack a day or 15 years of 2 packs a day. Current or former smokers who quit less than 15 years ago. But very importantly, CT screening does not substitute for stopping smoking. Unfortunately, lung cancer also occurs in never smokers, and it's actually quite common. If you look here in terms of annual deaths, death from lung cancer in never smokers actually occurs quite commonly when you look at the other cancer types. So 10 to 15% of lung cancers are not associated with tobacco exposure. This is usually an adenocarcinoma subtype, and it's very biologically distinct from tobacco-induced lung cancer in terms of it being a single driver mutation versus that of multiple gene mutations. Why is this? When people smoke, there's a lot of inflammation, a lot of carcinogens that go into the lungs. This causes a lot of abnormalities in gene mutations, and we see that there are multiple gene mutations that are what we call very heterogeneous. And non-smokers end up with lung cancer. Usually this is unfortunately bad luck. There is a distinct gene that gets turned on by mistake, and this drives the growth of the cancer and drives the spread. By blocking this gene pathway that drives the cancer, we're able to stop the cancer from growing and get the cancer to decrease in size and hopefully go into remission. Lung cancer diagnosis and staging. Patients unfortunately do present late, but we normally try and get blood work, assess the tumor in the lung with CT scans or chest X-ray, and very importantly, get enough tissue for what we call molecular gene testing and biomarker testing to see who will predict response and best choose treatments for our patients. We will biopsy assess metastases or biopsy the lesion in the lung, and then look for common sites of spread in order to properly stage and treat. This can be a PET CT scan or MRI of the brain, looking at the obvious sites of spread, which include brain, spine, liver, lung, bone, and these are the common sites, including that of adrenal glands. We treat non-small cell lung cancer after we've staged it. This is usually the size of the tumor, lymph node involvement, and then whether there are any metastases. When patients have metastatic spread outside the lungs, this is deemed stage 4, and treatment, unfortunately, is palliative. Stage 1 and 2 is still deemed curative, and this is usually a peripheral lesion in the lung. When you're looking at stage 2, there can be some spread to a local lymph node, but this is still surgically resectable, and we give what we call adjuvant or extra chemotherapy after surgery to try and mop up whatever cancer cells that are microscopic to increase the chance of cure. When we look at stage 3A, usually the mediastinal, or what we call N2 lymph nodes, are involved. These are further away from the tumor, and this involves multimodality treatments of surgery, radiation, and chemotherapy. I wanted to update you at the latest European meeting a few weeks ago. The addition of extra radiation to the mediastinal lymph nodes was not deemed to be incredibly helpful. It decreased the chance of the cancer coming back locally, but did not improve survival. So at this time, we're waiting for the final publication before we change care, but this has ramifications in terms of completely changing our standards of care. It does seem that patients that receive radiation actually had increased deaths due to cardiac toxicity. In terms of stage 3B, chemoradiation is the most common strategy. And you can see that until you hit stage 4, the intention is still curative, although by stage 3B, we're looking at 20 to 25% cure rates. When we're looking at stage 4, the intention is palliative to prolong life expectancy, control symptoms, and rarely put patients into remission for long-term survival. The treatments we have usually go into the vein or by mouth, such as chemotherapy, targeted therapies, or using the immune system to target the cancer. So this is where we were ages ago. It was a very sad and pathetic, it was a very difficult career, choosing an early career in lung cancer. We saw patients in the emergency, and as soon as they had the diagnosis of lung cancer, we basically said there was nothing we could do, and patients would go straight to hospice. So here they say, of course you don't feel any better. 2 years ago, I gave you 6 months to live. You do the math. Well, I'm pleased to say that we have made a lot of gains, and it has gotten better over the years, and there's a lot more hope. Palliative chemotherapy was even questioned until a Canadian group looked at whether chemotherapy would be helpful or not in 1995. It was deemed that chemotherapy had horrible side effects of nausea, vomiting, and low blood counts, and if patients had a good enough performance status, whether they would benefit in terms of chemotherapy. Well, this major trial in 1995 determined that chemotherapy decreased the symptom of coughing blood, cough, pain, and poor appetite, as well as shortness of breath, and had a small, and I mean small, advantage in terms of survival. The 1-year survival improvement was about 10%, and the median survival improvement was about 6 to 8 weeks. In general, patients would live 6 to 8 months, and this would be expanded to that of 10 to 12 months at best. So moving from 15 years ago into standard therapy 10 years ago, we got better in terms of looking at platinum-based chemotherapy, and it had a few more tools in our toolbox. We were able to separate the two histologies of adenocarcinoma or non-squamous and realize that they behave differently than squamous, and that chemotherapy regimens differed in terms of their effectiveness. The new drug bevacizumab, which was an anti-angiogenic agent attacking blood vessel growth, was used. However, it could not be used in squamous cancer as it caused massive hemoptysis and death from bleeding. Overall, the side effects seem to justify the improvement in response rate and survival when given with chemotherapy, or the regimen of pemetrexed and cisplatin was chosen for adenocarcinoma. For squamous, gemcitabine was more effective. and then chemotherapy for second-line treatment and third-line treatment. I want to focus a little bit on erlotinib. Erlotinib is what we call an epidermal growth factor receptor. It was deemed in 2004 to be in an unselected population better than best supportive care after platinum-based chemotherapy. This was an unselected population and included people that were not in as good shape as well. Those were ECOG performance status 3 that were spending most of their time in bed. These patients could not receive chemotherapy due to the toxicities, and still there was a small improvement in terms of survival. However, within the small improvement in survival, there were certain patients, a small number, that had a dramatic improvement. Usually these are patients that had rash and those that had never smoking histories, that were female and Asian most commonly, and they had a dramatic benefit where the cancer shrank away in weeks. And so we have spent the last 10 years trying to define what it is that predicted such a dramatic response to this line of drugs. Currently, we're looking at personalizing therapy and looking at markers to determine whether patients will respond to treatment or not, and what the best treatment options will be for our patients. So we take tissue or we take blood samples for biomarkers to predict response, and first-line therapy has now changed to become either targeted treatments or immunotherapy, and second-line therapy is still either targeted or chemotherapy with the advent of docetaxel and ramucirumab in 2014, which improved survival for a few weeks. So as previously mentioned, we went from seeing non-small cell lung cancer as one disease to being separated in terms of different histologies such as squamous and adenocarcinoma in terms of how we treat with chemotherapy, but not only how we treat, but the characteristic driver gene mutations and the gene mutations that we see for both histologies. You'll note that adenocarcinoma, which is more commonly seen in non-smokers, has a lot more what we call driver gene mutations or single gene mutations that drive the growth of the cancer. Squamous cell cancer is more associated with smoking and has a variety of different mutations that we're still struggling to try to better target. Even in this adenocarcinoma or non-squamous pathway, you'll see that the genes differ from that of former current smokers and that of never smokers, particularly that of EGFR gene mutation. It's very commonly seen in never smokers. And ALK rearrangement is more commonly seen, whereas in former or current smokers, EGFR gene mutation is less commonly seen, but KRAS is seen quite commonly, as well as BRAF is seen a little more commonly than that of in never smokers. So I'd like to move to EGFR gene mutations. These were characteristic mutations in exon 18, 19, and 21. As you'll see later, exon 20 did not respond to any of these drugs and was very difficult to treat. So for these gene mutations, there was a 15% overall mutation rate, more commonly seen in 30 to 70% of non-smokers. So it's really important that we think of testing for this gene in non-smokers. Initially, these drugs were being used second and third line in unselected patients. But once we saw that there was this gene mutation, we moved it up front to first line. And this was a major trial showing that erlotinib or gefitinib and other EGFR tyrosine kinase inhibitors, which are pill therapy by mouth with few side effects and side effects very different from chemotherapy, had a dramatic response rate and a huge improvement in survival over first-line chemotherapy that was previously standard. And at this time, most of these agents have a response rate of 70 to 80%, they improve the median progression-free survival by about a year. And this compares favorably to that of traditional chemotherapy, which had overall response rates of 20 to 30% and only improved the progression-free survival by about 3 to 6 months. These EGFR inhibitors went into first-line treatment for patients that were EGFR mutated in exon 18, 19, and 21. But after about a year, on average, patients stopped responding. So biopsies were done to see why they stopped responding and what was happening. Although some of them had transformed to a different type of cancer, such as small cell cancer, or they gained what we call a MET gene amplification, or a MET gene mutation, or HER2 mutation, as we'll see later. The vast majority of these patients developed a resistance mutation that arose called T790M. This was in 50 to 60% of our patients. And as a result, a new drug, osimertinib, previously called AZD9291, had this waterfall plot where cancers dramatically decreased in size with a huge response rate and activity in the brain with osimertinib in this early phase trial. The response rate was 61%, and patients that had this resistance mutation would have a progression-free survival almost slightly less than 1 year. So patients now, instead of living less than a year with chemotherapy, could receive first-line EGFR tyrosine kinase agents and live for an extra year. And then at which point, if 50 to 60% of them develop this EGFR T790M mutation, then they would live for another year. So then somebody said, well, this drug works so well after treatment with a tyrosine kinase inhibitor, why don't we consider using it up front? So the FLORA study was recently published 2 years ago, looking at osimertinib in untreated EGFR mutated advanced non-small cell lung cancer, looking at this up front, and there was an overall survival advantage favoring osimertinib, partly because it prevented the development of the T790M resistance mutation and encompassed more patients. Also, it was exceptionally well tolerated with much less rash and diarrhea. And recently updated at the European meeting in 2019, it was determined that osimertinib had a median overall survival of 38 months, which is almost 3 years when given upfront. So that's quite remarkable in these EGFR mutated patients compared to previous. Not surprisingly, the main benefit was the fact that while chemotherapy does not penetrate in the brain, and brain metastases are a major cause of morbidity and death in lung cancer, osimertinib actually had a great response in patients that had brain metastases in terms of getting into the brain, preventing the development of metastases, or treating the metastases that were present. So the ADORA study was recently just presented and just published 2 weeks ago in New England Journal of Medicine, looking at what if we use osimertinib further up front after surgery. This was looked in patients from stage 1B to 3A, and their main endpoint, which was disease-free survival when given for 3 years after surgery, had dramatically improved the disease-free survival. It also met its secondary endpoint of improving disease-free survival in patients overall that included stage 1B as well, but most of the benefit was the highest in that of stage 2 and 3A disease, as you see here. So there's quite a difference for osimertinib versus placebo. This trial is still not mature and we're still pending FDA approval of this agent for after surgery in this setting. However, in the early trial, this trial only looked at 5% of the population, and we're not sure if it actually improves survival overall, or if we're only pushing out the disease for 3 years before patients actually progress. So it's hard to know if we're actually curing patients with osimertinib or if we're pushing out the disease, and we will not know that for some time. But at this point, it's pretty dramatic in terms of the disease-free survival benefit. And most of the disease-free survival benefit was shown in the New England Journal article to be due to the decrease in the development of brain metastases in those treated with osimertinib. Hopefully this will soon be a standard of care. We talked about the EGFR mutations 18, 19, and 21. However, exon 20 has been almost never sensitive to the agents that we talked about. There has been a lot of effort over the years trying to target exon 20, and currently there are some new agents in development that are showing good responses, and we're working with the toxicity of these agents, but they're very promising for eliciting responses and treating exon 20 insertion. These are still in early development. When we look at the ERB family, HER2 is also an area of interest. HER2 exon 20 insertions are also being looked at. These are in 2 to 4% of lung cancer patients, usually exclusive of other oncogenic drivers. And so as you see with EGFR, when you have an EGFR mutation, you usually do not get another driver mutation. And this is usually in female Asian never smokers. Pozizotinib and teraloxinib are very exciting agents that look very active. And then when we looked at those that are being treated with osimertinib now up front, the standard of care has just changed so rapidly in the last year that we're trying to figure out patients that are progressing on osimertinib by biopsies, what the mechanism of resistance would be. And some of these agents are in development, are looking very promising. HER2, HER3, and HER4 are sometimes seen in terms of EGFR resistance and are being targeted, as well as the c-MET pathway is targeting this resistance pathway as well. And these are very early in development. Well, we talked about EGFR, which is very common in never smokers. The second most common in never smokers is ALK. This is an ALK gene mutation and is quite common at 11% in never smokers. It's about 5% of lung adenocarcinoma overall. We diagnose it with a fluorescence in situ hybridization assay. And in 2011, based off of 2 small phase 1 studies with a few patients, there was a dramatic response rate of 60 to 70% and an improvement in survival for those that were ALK translocated of almost a year. And this was approved for first-line therapy. Since that time, I was the investigator on the ceritinib trial, and we were amazed that after patients had progressed on crizotinib as a second-line treatment, patients had this beautiful waterfall plot where they dramatically responded within weeks. This was a patient of mine that went from 4 weeks to later having almost no disease on the PET scan. So this was remarkable and led to the early approval of ceritinib. Last year, we presented the data of ceritinib on brain metastases and measured its effect on brain metastases in patients with leptomeningeal disease or cancer cells in the brain and spinal cord, and at which point this drug is exceptionally active in the brain as well. Alectinib was also what we call another second-generation drug, which was very active after ceritinib was approved. At which point, alectinib was compared versus crizotinib in the first-line ALK-positive non-small cell lung cancer patient, and there was a progression-free survival an overall survival advantage over crizotinib, and mainly because of the fact that it decreased the risk of CNS progression and had effects in the brain. So when we look at these ALK inhibitors that are now being developed, the remarkable thing about targeted therapy is its ability to target the central nervous system and the brain. Chemotherapy has never been particularly active for brain-based disease, and we always questioned whether we should even treat patients with uncontrolled disease in the brain with chemotherapy at all, because it was a major cause of death. When we look at crizotinib, it wasn't the fact that crizotinib was not active in the brain, it's just the fact that the concentrations were not adequate, it was not potent enough, and patients would progress after roughly 6 months. When you look at the newer agents that have been developed from ceritinib, as well as alectinib, brigatinib, and lorlatinib, the ability to control disease in the brain and have cancer in the brain decrease in size was remarkable and lasting over that of a year or has not been reached. So we used to treat patients with crizotinib as first line. I would say at this time it's no longer the standard of care. Patients that were treated with crizotinib then went on to ceritinib, and then when alectinib got approved, they responded to alectinib, and then brigatinib and lorlatinib. And I actually have patients in my practice that have been on these ALK inhibitors, being ALK mutated. There's people that are still doing well and working full-time 7 to 8 years later, because they went on to these early trials and then went on to receive further ALK inhibitors as they got developed with time. The great thing is, if we're able to control disease and prevent death up front, the area of drug development in this area is so rapid that every few years there has been a new drug, and there has been incredible hope for our patients in terms of prolonging life. In particular, recently this year, alectinib versus crizotinib first line had a progression-free survival of almost 3 years and 62.5% 5-year overall survival. Brigatinib looked at a progression-free survival of 2 years and overall almost 30 months with an investigator assessment, and this is still ongoing. Lorlatinib was recently presented at the European meeting as having reached its endpoint with not a firm progression-free survival yet. So what we've done is we've developed better and better drugs and use these drugs and move them in the frontline setting further up to prevent resistance mutations and to get a better effect so that patients live longer. As a result, this has changed our standard of care, but the field is moving so rapidly that because our standard of care keeps changing, the trials that take several years to design and work through are unfortunately then rendered not so helpful, and we have to redesign a lot of our trials. But the interesting fact is that these agents are being developed in such a rapid manner, and there's rapid early approval in early phase 1 trials, which is almost unheard of. So this is a patient of mine, Mr. F.H. He's a real patient, 50-year-old man with a remote 10-year packed smoking history. So he didn't smoke very much. He presents with rapidly worsening symptoms. 6 weeks ago, he had cough, abdominal pain, diarrhea, cramping, anorexia, nausea, and worse in the last week. Unfortunately, he also turned yellow and was looking terrible. CT scan showed a mass in the right lung, a pleural effusion, a liver metastasis, bone metastasis on CT. His MRI of the brain was negative, but this is a man that went from jogging every week to becoming completely debilitated and near death and was very yellow. So not only was his liver enlarged and he had fluid in his lung, but he had very bad impending liver failure, and his lab showed a white blood cell count that was exceptionally high, which is a bad prognostic sign, as well as a high LDH. Biopsy showed adenocarcinoma consistent with non-small cell lung cancer. So obviously we needed to rapidly do what we call molecular testing, looking for a driver mutation. And because he hadn't smoked very much, I was hopeful that he might have an EGFR and ALK mutation, as we previously discussed. And maybe that would save him and lead him to not die in the next few weeks, because that's where he was heading. So this is his pathology. And his pathology comes back negative for EGFR and ALK. So this was very disappointing. So this was him before, and this is him 4 weeks later. The liver lesions had dramatically decreased in size. He was feeling better. He was no longer yellow. Liver enzymes returned to normal, and he was almost back to, well, he was walking, not quite running again, but something had happened in the interim. So his ROS1 gene mutation came back as being positive. So ROS1 is in 2% of non-small cell lung cancer, never or light smokers, and it's mutually exclusive with EGFR and ALK. So it's in 5 to 7% of never smokers who are EGFR and ALK negative. The response rate to crizotinib was 72%, which was incredible, and patients rapidly improved in terms of weeks, and the duration of response was about 1.5 years or longer. Since that time, there have been a dramatic improvement and increase in the number of agents being used to target this not very common gene mutation, and crizotinib and entrectinib recently have the FDA approved, and they have really high response rates, but particularly in those with brain metastases, there is a lot of activity and a lot of response. And looking at lorlatinib and repotrectinib, these two are newer agents that are in development and hopefully soon to be approved, but these two agents are very active, in particular in terms of the response rates and in patients with brain metastases and their effect in the brain. In terms of tyrosine kinase activity in pre-treated ROS1 positive patients, patients that already had a prior ROS1 inhibitor, such as crizotinib or entrectinib, still responded to these later agents, such as lorlatinib and repotrectinib. These are early studies, and we'd like to better define this population in terms of what kind of resistance mutations may have formed to better select treatment for lorlatinib and repotrectinib. So updated, the response rate in 2020 for entrectinib had an overall response rate of 73%, and lorlatinib was looking very active and in the first line, in the second or third line setting, with an overall response rate of 62%. What about c-MET? So c-MET exon 14 skipping mutations are seen in 2 to 4% of non-small cell lung cancer, also in never smokers with adenocarcinoma. Crizotinib had a response rate of 33% in 13 patients, but since that time, capmatinib has been deemed to be a highly selective, potent MET inhibitor with very good CNS penetration. Topotecan is also selective and has some activity in the brain. As you can see here, there's activity in those that are treatment naive and those that have had more than one line of treatment. The discontinuation rate due to side effects is actually fairly low, and even lower for that of topotecan. Capmatinib, which had more mature data, was approved by the FDA in May of 2020. And then we move to RET gene fusions. This is in 1 to 2% of non-small cell lung cancer in non-smokers. And in the past, we used this dirty, or what we call multi-targeted anti-angiogenic agent, which hit a lot of receptors with a lot of side effects. This is known as cabozantinib, and it had a response rate in 28% of patients. However, in the last year, we're really excited that there are much more selective, exceptionally more potent RET inhibitors that only target RET with high potency. And these drugs were recently presented with high response rates, as you can see here, of 70%, 60%, and good brain penetration such as response rates in the brain. LOXO-292 or selpercatinib had a response rate of almost 93%. It had a good response rate in those previously treated with platinum, and also in the upfront setting for patients that were treatment naive of a 90% response rate. The discontinuation rate due to side effects is very low at 2%. So both these drugs were recently just FDA approved, and both are available. And we're really excited that now we have 2 drugs available for this population. Although we don't see these driver gene mutations very commonly, when we do see them, the ability to treat them with these targeted oral drugs is just remarkable in terms of how quickly and how well they respond, and the side effect profile is so tolerable. BRAF V600 mutation is a little bit different. It's seen in 1 to 3% of non-small cell lung cancer, adenocarcinoma, but more commonly seen in smokers than non-smokers. And when we looked at this trial of trametinib and dabrafenib, the response rate was 63% in a few patients, and this was fast-tracked and approved in 2017. Again, you see this waterfall plot where the cancers are dramatically decreasing in size. Finally, we look at this very rare gene mutation known as NTRK. NTRK is not a very common mutation, and comprising of 0.05 to 0.2% of non-small cell lung cancer. Importantly, it's seen in squamous and non-squamous adenocarcinoma histology. And this has been approved across the board in any NTRK gene fusion driven cancers. Both larotrectinib has a response rate across all tumors at 75%, and entrectinib has a response rate of 57.4%, and both are FDA approved. So it's really important, due to the high response rate and activity, to at least check for NTRK in non-small cell lung cancer, and to include checking this in squamous cell carcinoma histology. Since 2009, we've known that targeted oral therapies in advanced non-small cell lung cancer improve survival. And if you look at where we are today, we're looking at several years of survival that far exceed this graph that ended in 2009. So since that time, look at the rapid rate of discovery and then subsequent FDA approval. I found this to be quite exhausting, looking at the number of new drugs that were approved for EGFR exon 18, 19, 21, and other sensitizing mutations. We moved from discovery in 1978 of these agents to FDA approval in 2004. But then in the last few years, osimertinib was being looked at in 2009 to 2012, and then was approved 5 years later. Subsequently, we look at the first ALK agents that are being approved in a very rapid manner, and the rate of drug discovery and accelerated approval is moving so quickly in this field that, unfortunately, due to COVID, I could not attend, obviously, most of the major meetings this year. And I was struck while making this presentation and looking at all the drugs that recently been approved and are under study in the last 2 years, how much has actually changed in the last year while we're all trying to survive the pandemic. So it's pretty amazing that there's been so many drugs approved in the last 2 years, as well as so many new gene targets that we've discovered drugs for that are highly effective, potent, and selective. One area to look out for is KRAS. As you see, this is more commonly in that of smokers. But for the last 2 decades, we knew that KRAS mutations were a major part of non-small cell lung cancer. We could just never find any drugs that worked for it. And most recently, The Amgen 510, which now has a name, is undergoing accelerated fast track for FDA approval, as well as the Mirati compound MRTX849. And so these are agents that target a specific KRAS G12 mutation, overall seen in 13 to 15% of lung cancer. So this has been a major area of breakthrough that we should keep our eye on, and hopefully we'll be hitting FDA approval soon. I also had a great time looking and trying to summarize all the drugs for molecular targets in non-small cell lung cancer in terms of KRAS, EGFR, ALK, and all the other targets. And what I've listed are a number of the approved drugs in bold. I've also indicated those that are in development here with this tiny asterisk, as well as those that are being used off-label for these targets are being starred here. So this hopefully formulates a reasonably good summary as of 2020 of all the drugs in development, approval, and being used off-label. So I think this is remarkable where we've come from in terms of chemotherapy to now all the available molecular targets and drugs that are in development at this time and available for our patients. Well, an area that is very close to my heart is that of immunotherapy for lung cancer. For about 20 years or more prior to this major study in 2012 that was published, we had been trying to target the immune system in lung cancer forever, using a variety of agents and vaccine treatments that were all hideously negative. And so by the time I put this patient onto this trial in 2011, we said, you know, there's nothing else in our phase 1 program. There's no way immunotherapy is going to work. Hey, there's this anti-PD-L1 inhibitor. Maybe we should put this patient onto this trial because they're fit and there's nothing else they can have, and they've exhausted all treatments. And so this patient was not feeling terribly well. And 15 months later was back to working full time and was almost in a complete remission. So we're like, wow, that's amazing. What happened? And so we enrolled 61 patients onto this trial with non-small cell lung cancer at the University of Washington. And we became really excited that these anti-PD-1 or anti-PD-L1 antibodies would actually unmask tumors to the immune system and stimulate the immune system to go out and find these tumors and destroy them. So it was pretty amazing because the side effect profile of these treatments given intravenously were actually very mild and very tolerable. So this is a patient of mine, Mr. PB. He had a very difficult time with balance, headaches, nausea, and vomiting, and was a heavy former smoker of tobacco and marijuana. Well, he's still smoking marijuana. Unfortunately, he had a very big brain metastasis causing mass effect that was resected, and it showed EGFR ALK negativity, which was not surprising as he was a heavy smoker, and he did not have any characteristic gene mutations. We talked about smokers having a lot of inflammation and a lot of what we call heterogeneous gene mutations or mutational burden. And so this would be a very characteristic person that would respond better to immunotherapy. He had a large mass in the brain, and he had progressed after first-line therapy. So at that time, pembrolizumab selected out patients that had some expression of PD-L1 on the tumor cells and compared it after platinum-based therapy versus the standard second-line treatment of docetaxel in this phase 2/3 study that demonstrated overall improvement in survival favoring pembrolizumab. And this became standard of care as the first agent, second line. The Checkmate 057 in non-squamous, as well as the Checkmate 017 in squamous cell cancer, also demonstrated that nivolumab, an anti-PD-1 inhibitor, was compared to docetaxel standard and also demonstrated improvements in survival. Response rates were 15 to 19% overall, and patients would have a reasonable time to response and a duration of response that was substantially longer than that of second-line docetaxel, which was about 5 to 6 months, whereas the duration of response was up to 17 months. What soon followed was approval for atezolizumab, the anti-PD-L1 inhibitor, versus docetaxel, based off of overall survival benefits in an unselected population. So Mr. PB, after 7 years of anti-PD-1 therapy, remains in remission and has not had any progression of its disease. And it's actually a true story, and he's still around today. But we began to think, hey, you know, maybe immunotherapy actually cures some patients, and they do well. Although we didn't really have a very good idea of when to actually stop the anti-PD-1 therapy, so he's still continuing treatment. So this was a compilation and pooled analysis of 3-year survivors from the nivolumab second-line Checkmate 017 and 5-7 studies. And you can see here that this is a tail of the curve where there's some people that were still surviving 3 years and beyond. So what was it that was characteristic about these patients? Well, they were usually current or former smokers. And sadly, even though I tried to tell my patients to stop smoking, they already have lung cancer. It seemed that those that kept on smoking had the continual inflammation and continued response to immunotherapy. Those that were non-smokers and had a driver EGFR mutation did not do as well. And those that did not have the mutation tended to do better, as this was a less inflammatory situation and there's only a single driver gene mutation. Although those with a high PD-L1 status on their tumor cells tended to do better, it's important to note from these trials that patients that were negative for PD-L1 still responded and had a low long-term survival. So these patients did exist and tended to still do well. So it was felt that at that time, patients that were negative for PD-L1 still benefited from immunotherapy. And if you look at the fact that if they didn't have a targeted gene mutation and they had progressed after chemotherapy, there really wasn't very much for our patients at that time. So characteristic of how we move with the targeted agents, if drugs are so great in second line and beyond after chemotherapy, how about moving them into first line and giving them up front and trying to do better than chemotherapy, which we know is kind of toxic and not that effective. So in this pembrolizumab study in 2015, it was very clear that when we use PD-L1 expression on tumor cells, that the higher the expression, the more inflammatory the tumor, and the chance of response is much better at 45.2%. And this was a relatively good biomarker to predict response. And so this Keynote 024 phase 3 study looked at first-line chemotherapy and compared it to first-line pembrolizumab in the population that was greater than or equal to 50%. And the overall survival advantage benefited pembrolizumab, establishing it in standard of care for those that are greater than or equal to 50% PD-L1 expression as a companion diagnostic. In combination with chemotherapy versus chemotherapy alone first line, pembrolizumab also had improvement in overall survival. Interestingly, the benefits were across the board in terms of those that were less than 1%, 1 to 49%, but was highest in those that were greater than or equal to 50%. In fact, response rates were as high as 65%. So we still have a question in our minds and a controversy for those that are greater than or equal to 50%, whether we just treat these patients with pembrolizumab alone or if we should consider pembrolizumab plus chemotherapy. And the recent update at ASCO in June demonstrated that patients that were treated with just pembrolizumab actually had a really good long-term survival and did not require necessarily the side effects of chemotherapy. So we're waiting to see the final analyses and the final discussion regarding this, but at this time, both agents represent a standard of care for those greater than or equal to 50%, and for chemotherapy and pembrolizumab is a standard of care overall for all our patients up front that do not have a gene mutation that's targetable. So nivolumab was looked at in the Checkmate 026 study, the anti-PD-1 inhibitor versus chemotherapy up front. And it was a disaster for nivolumab because it was negative. And for a long time we thought, well, maybe nivolumab is different or it's not as good as pembrolizumab. But, you know, we couldn't really do cross-trial comparisons. And maybe it was just trial design and it had nothing to do with the drug. Well, recently published in the Checkmate 227, which was a several-arm study, nivolumab plus ipilimumab, which is this anti-CTLA-4 inhibitor that you may be more familiar with in melanoma. It's another immune checkpoint inhibitor. Both of these agents, despite having substantial toxicity, was compared to that of platinum-based doublet as first-line therapy. And in those that had PD-L1 greater than or equal to 1%, there was an improvement in overall survival, and this was FDA approved May 15th, 2020. Unfortunately, with this study, their initial endpoint had not quite been reached. They tried to look at mutational burden as a biomarker, and then they reanalyzed it using PD-L1 expression, which subsequently was positive. Even though this has been FDA approved, we're not sure where the combination lies at this point and whether it would supersede that of the pembrolizumab and chemotherapy that we showed that we have been using already for several years now. Also, at the same time, on May 26, 2020, as presented at the June meeting of ASCO, the American Society of Clinical Oncology, the Checkmate 9LA study looked at nivolumab for 2 cycles with ipilimumab, followed by 2 cycles of platinum-based doublet chemotherapy versus 4 cycles of chemotherapy as first-line treatment. And it did seem that this met its overall survival benefit and has subsequently been FDA approved. Not to leave behind the fact that when these drugs are effective, we move them from the advanced setting where there's no other therapies in the second or third line setting and beyond in metastatic disease to first line. But what about moving it even further? So this is the Pacific study looking at the anti-PD-L1 inhibitor durvalumab compared to that of placebo in an unselected population after chemoradiation in earlier stage 3 disease that was treated with chemoradiation. And overall, in this unselected population, durvalumab had an improvement in progression-free survival over that of placebo, and subsequently has been demonstrated to have an improvement in overall survival, and is now the standard of care. So we're looking at strategies to convert T-cell poor tumors in these non-inflamed tumors into T-cell inflamed tumors to increase the depth and duration of response and initiate response in those refractory to immunotherapy. This can be combinations of radiation, chemotherapy, targeted treatments, or a variety of other immunotherapy agents that are now in development. This is a huge area with more than several hundred combination checkpoint inhibitor trials in non-small cell lung cancer at this time. So in summary, non-small cell lung cancer is a major cause of morbidity and mortality. Prevention, i.e. patients should stop smoking as soon as possible, and early diagnosis such as screening are key to decreasing the morbidity and mortality. While overall advanced non-small cell lung cancer still has a bad prognosis overall, these new advances have improved survival and quality of life. There are many emerging targeted therapies and immune combinations that are effective with manageable toxicities, and we need to know how to best sequence and select the patients for these treatments, as these groups are quite diverse. For my patients that are smokers, I think upfront that I would like to consider immunotherapy and check them for PD-L1 expression. For my non-smokers or light smokers or previous smokers, I think upfront that targeted therapy would be a very good treatment, and we'll send out their molecular testing to look for targetable mutations. So in terms of future research directions, targeted therapy, we're finding so many new targets for oncogenic driver mutations. There's increasing lines of targeted therapy after progression. So what's been happening is you progress on your first line targeted therapy, you have your second one, you have your third one, which you respond to, and patients live years now. And there's still chemotherapy at the end after progression off of all targeted treatments. This field is so rapidly changing that the standard of care keeps changing so rapidly that we're revising all our trials constantly. And similarly, we're moving these targeted therapies into earlier settings, into first line, into adjuvant therapy, neoadjuvant therapy, and a maintenance treatment. We're also looking at targeted therapy in squamous cell lung cancer and seeing if there's relevant targets that are effective there as well. But this is still a huge area for development. When you think of squamous cell lung cancer, this is more associated with smoking. And we also were thinking for smoking related cancers, we think that immunotherapy would be likely the most effective. And again, immunotherapy with the PD-1 checkpoint inhibitors and other checkpoint inhibitors are moving into earlier settings to increase cure. Again, neoadjuvant, adjuvant, as well as in other settings. We just need to get better biomarkers. Combination therapies are very important for improving the response rate and trying to put patients into partial or complete disease remission, and also focusing on this refractory population that have failed initial PD-1 inhibitor or immunotherapy and trying to restore responses in that population using biopsies is a major area of development and research. So in summary, this is what I'd like to see for the future for advanced non-small cell lung cancer. We've seen that we've moved from living 6 to 8 months and for lung cancer being a death sentence to a lot more hope for improvements in survival, good tolerability, and the ability to change lung cancer into a chronic disease that people just live with, and hopefully moving into complete remissions and cures. So I don't know if you can see this below, but it says, so after they found a cure, will you continue in the field of medical research? So I thank you for your attention. I thank all the patients and all the investigators that have been on all these trials and researchers that have made this all possible, and all the tiny mice and preclinical work that's been done to advance the field so much in the last few years.
Thank you, Dr. Chow. That was great. I don't know how you keep it straight though. There's just so many different directions and so much research out there.
So I'd like to open it up for any questions. So there is a question and answer and a chat button. So please ask me questions. I know it's a little bit overwhelming, and hopefully you'll still have the slide to, you have the slides and the presentation to look through.
Looks like I don't think we have any questions. So again, thank you, Dr. Chow. We are recording this, and the recording of your presentation will be on our website. For those of you who are who have questions that might come up later, please feel free to email Elevate Cure Foundation, and we will direct your questions back to Dr. Chow, and we can respond online as well. With that,
thank you, everybody. And I would
thank you.
to be more interactive, but due to the pandemic and the platform, unfortunately, we're a little limited. Hopefully, I will see you guys at some other point in time. And I thank you very much, CC, for everything.
Yeah, you're welcome. Thank you. And Diana, we just got your chat. Thank you for your message. Have a good day, everyone, and be safe.